Hello, my name is Dr. Badamosi. I'm a pulmonary critical care physician, and I'm the medical director of Division of the Pulmonary and Critical Care Medicine at JPS in Fort Worth. And also, I'm the medical director for respiratory therapy in the same hospital. We're going to be talking about COVID-19, what our experience has been at JPS, and more broadly, to actually compare our experience with what is going on in other places and broadly review the management and rationale and therapeutics behind managing COVID-19 patients. And also to look at some areas of lessons that we've learned, and I guess a little bit also about the vaccine, since that is dominating a whole lot of conversation now. And as healthcare workers, we will be pestered with a lot of questions in the coming days and weeks in regards to whether or not to get a vaccine. And I'm sure some of us have been thinking about that too. I hope to provide as much information as I'm able to objectively in regards to what's going on. I want to start at the basic to look at the COVID-19 virus, the SARS-CoV-2. It belongs to a group of viruses, as we all know by now, coronaviruses. They are basically RNA viruses. Viruses are either DNA or RNA viruses. Coronavirus has been known to cause infection in humans and mammals and birds, and generally causes respiratory illness. To date, about 7 coronavirus species are known to cause human disease. 4 of those viruses, strains of which are listed here, they are very prevalent in our community, and they cause common cold symptoms. There are studies that have shown between 17 and 50% of all cold symptoms that we have in our community is caused by this coronavirus species. Obviously, the biggest cause of cold is the rhinovirus, but still coronavirus plays a significant role in causing cold and upper respiratory tract infection. While these 4 species tend to cause mild illnesses, there are 3 species that are highly pathogenic in humans, which means they can actually make us really sick and cause a whole lot of problem. So we've all heard of the SARS-CoV-1, the outbreak that was in Asia, Canada, and part of the United States in 2002, 2003. And of course, the Middle East respiratory virus that also caused an outbreak in the Middle East several years back. These are really highly contagious disease. And as we now know, COVID-19 or SARS-CoV-2 is the third of these highly pathogenic human coronavirus that cause human diseases. Now, I put in this timeline just to give an idea of our interaction with coronavirus. The first coronavirus was discovered in 1931, and in the United States around 1966, it was isolated in a medical student in Chicago. And subsequently, we've had all of these advances in our knowledge and understanding of coronavirus. Between 2002 and 2003, we had the first emergence of the SARS-CoV-1 that caused the SARS epidemic in Asia and in Canada and northern United States. Then, of course, by about 10 years later, in 2012, we had the MERS-CoV. These viruses are remarkably similar. On the average, they show about 80% homology in their DNA. Then, fast forward to now, or to present, about 10 years later, we have the SARS-CoV-2 that we're currently dealing with. Now, the interesting thing is, it seems approximately every 10 years, we have an emergence of a coronavirus that causes trouble. And most of this coronavirus really have an intermediate host, either bats, pangolins, or camels, as was the case with MERS-CoV. And of course, here now we think it's bats that fuel the rise of SARS-CoV-2. Unfortunately, there is more of coronavirus where all those 3 come from that could actually cause problem. And that's why I have the slide here to show that, yes, we hope this pandemic will be over, but a whole lot more trouble could be brewing in the background as new coronavirus could emerge at any time from any of these intermediate hosts. So this is the SARS-CoV-2 virus that we're dealing with. And this slide is a little bit important. I will be making multiple references to this slide. So this is the basic structure, which we have all seen on news media everywhere. And if you take a cross-sectional look at it, basically, this is the RNA, the genetic code. And the red thing here in this cartoon is the envelope. It's made up of lipid. And sticking out on it is the spike protein right here. It also has minor proteins, which are antigens that the human immune system can recognize. M protein, then the hemagglutinin esterase enzyme, then of course the E protein. So we have a lot of proteins sticking out on the surface of this virus, the most significant of which is the spike glycoprotein that our immune system responds to and direct antibody against. At the same time, the spike protein also creates a pathway for the virus to infect human cells, as we shall see shortly. So this is really the coronavirus in all its glory. It looks much more uglier than my prior slide will suggest. And you can see the transmission electron microscopy of the SARS coronavirus. These are the spike proteins right there that you can see. And this is coronavirus in a respiratory cell. You can see it's really taken over the cell and multiply manifold. Soon, this cell will rupture. As this cell had ruptured and release more coronavirus that will go on to infect other cells. I have this here to redemonstrate the pathway that the coronavirus used to get to the human cell and basically what it does. This is the coronavirus. It binds via these two receptors here, mainly this. This serves as a co-receptor, the TIMPRESS2, but is the ACE2 receptor. And I'm going to make additional reference to ACE2 receptor that it binds to. Once it binds to the soft with the spike protein interacting with these receptors, it becomes internalized into the human cell. And once internalized, the lipid envelope breaks down and the RNA of the virus takes over the protein synthesis mechanism inside the human cell. Essentially uses its genetic code to really create another daughter viruses, and multiple of those are released. In the process of being released, this cell becomes dead. And these daughter viruses really go on to infect other cells. And that's how the viremia causes a lot of problems. So epidemiology, just looking at it, this is as of 23rd of November. There have been over 60 million infections worldwide and about 1.3 million fatalities, as we all see every day on the ticker. Currently in the United States, over 13 million cases, and we're approaching or a little over 270,000 fatalities. This is quite interesting. I calculated it since the pandemic started spreading in the community in the United States, there have been one death every 60 seconds in the United States. So one death per minute with the coronavirus. And unfortunately, it appears as though it is accelerating. Bringing it home to Texas, there has been 1.2 million cases in Texas with about 22,000 fatalities. In Tarrant County, we surpassed 100,000 coronavirus infection with over 1,000 deaths so far. Here in JPS, all of these numbers have changed, unfortunately. There have been over 4,000 cases in JPS that have tested positive. Not all of them have been admitted, as you will see shortly. And so far, 142 deaths in JPS as the last time I accessed the data, which I'm sure has changed, unfortunately. Now, again, this is what I just said earlier. This is from Johns Hopkins. This is the total cumulative case in Texas as of 23rd of November, about 1.1 million cases so far, and 21,000 deaths so far. Unfortunately, you can see the direction of the graph that it's beginning to pick up. And generally, we all know deaths from coronavirus lags 2 to 3 weeks behind. So looks like we're headed for a rough patch in the next several weeks. Bringing it home again, specifically to JPS, this has been all patients admitted to JPS. If you really break it down by race, you will find out that the Hispanic or Latino community has had about 47% of all JPS admit. And while Blacks, 26%, white, 20%, and Asian, there appears to be no genetic predisposition. Rather, this really appears to be socioeconomic. That's the best explanation I have found so far to explain the demographic preference for minorities. So I put this in there. I actually got this from JPS website. I want this to give us a little bit of perspective in terms of what's going on. These are all the patients that really have shown up at JPS. You can see overwhelming majority, over 2,000 patients actually are never admitted. They are managed effectively as outpatients, and about 700 more are actually discharged from the emergency room. Some present to the urgent care, about 257 are discharged. To our emergency room, we have about 1,100 patients, and of those, about 1 in 10 ultimately will go to the ICU directly from the emergency room. And majority of inpatient hospitalization of patients that are admitted actually goes to our IMC, over 800, about 8 in 10. About 200 goes to med-surg, and OB also have a fair share of patients going there. So I put this in there to give a perspective that what we see in the ICU is just really the sickest of the sick patient. Now, this is a continuation of that. This is the 1,100 patients that come through our doors, through the emergency room. And as you can see, the bulk of those patients get admitted to our PCU, and some of those patients end up in the ICU. So non-ICU patient is really about 80 to 90% of the patients that are admitted to the hospital. But if you look at the expiration, the additional slide is about 142, and most of it are ICU patients. So most of the expiration that takes place in the hospital actually take place in the ICU, about 95% of all of the expiration. So we tend to see a skewed impression or a skewed data in the ICU when we see a lot of mortality. Narrowing it down now to the critical care unit. So far, all of the data I'm showing is from February 1st to September 30th. So looking at our ICU specifically, the average age is 56 years old of people admitted to JPS ICU within February 1st and September 30th. Males are slightly younger, at about 55 years old, compared to the females that are 57 years old, giving us an average of about 56 years. This is no different, actually, if you look at data from other places. You can see the peak incidence for coronavirus of confirmed cases is between the age of 50 to 64. So this is a very robust data that shows that we are actually seeing similar demographics, at least in terms of age, admitted to our ICU. But unfortunately, as we all know, the older you are, the higher the mortality. Earlier on, I showed hospital admission by race and ethnicity. This is ICU admission by race and ethnicity. You can see, as anybody that has been in the ICU know, that majority of the patients admitted to our ICU, about 38%, 4 in 10 are Hispanic, and about 3 in 10 are Blacks, 3 in 10 white, and of course, Native American and Asians make about 1 and 4% respectively. So this is ICU admission by sex. No surprise here also. 64% of patients admitted to our ICU between 1st of February and 30th of September were male, and about a third were female. These are the raw numbers here. So length of stay. These are patients here that had ICU stay, and these are patients with no ICU stay. Clearly, the ICU stay is about 20 days. The people that go to the ICU stay in the hospital in total about 3 weeks, with about 10 days in the ICU and 10 days out of the ICU. People that had no interaction with the ICU have a very, very short length of stay, less than a week generally. If you're admitted to the PCU or if you're admitted to the medical ward, you can expect to spend between 5 and 7 days in the hospital, compared to 3 weeks if you have any interaction with the ICU, which is understandable and which I'm sure is the impression of most of us. This is our JPS ICU mortality. For all comers to our ICU, from February 1st to September 30th, about 40% of all admission to JPS ICU have died, unfortunately. And these are the raw numbers. So these are the proportion alive, and about 75 people, giving us about 40% mortality. Now, if you break it down a little bit further, 67% of patients, about 2/3 of patients admitted to ICU will end up on mechanical ventilation. And of those that end up requiring mechanical ventilation, about 53.1% will die. So you can see for all comers to the ICU, the mortality is 40%. For people that are intubated, the mortality is 53%. So if you come to the ICU and you did not get intubated, the likelihood of dying is less. But once intubated, the mortality jumps up. How do we compare to other centers? I have tried to collate a few studies that have looked at this to look at what is the mortality in other centers. You can see various authors have published their mortality ranging from around 16.7% at Mass General earlier on in the pandemic before Boston became a major epicenter, to all the way to 88% in New York during the peak of the pandemic in New York. And in between, you can see the numbers. So we fall somewhere in between in terms of mortality of 40% for all ICU, in terms of our mortality of 53% for all intubated patients in our ICU, which is right here. Proportion of patients requiring invasive mechanical ventilation in various ICUs. Look, in Italy, 99% of their patients require to be intubated. In China, about 3 in 10 patients will require mechanical ventilation. And in the United States, we're currently really about 80–90% of patients admitted to the ICU in the United States end up being intubated. Again, we are at 67% of rate of invasive mechanical ventilation. Again, just to summarize the data that I have stated so far, if you are intubated in our ICU, the mortality is 53%. This is 67% of all the patients admitted to our ICU, with a mean stay in the hospital of about 3 weeks. And they stay typically, of those 3 weeks, 13 days or 2 weeks in the ICU on the average. And if you are not intubated, the mortality in our ICU is 14.5%, a difference of 40% in mortality. And mean ICU stay is 5 days for a mean hospital stay of about 2 weeks, and this is 1 out of every 3 patients admitted to our ICU. So this is the summary of our ICU data. Now, the other thing is, why is testing so confusing? We've had various information about the test that is available. What is the rationale behind all of those testing? This is the best data I could find that really nicely summarizes what we need to know in regards to testing. There are 3 basic different types of tests. You have the molecular test, you have the antigen test, and you have the antibody test. The molecular test basically just look for the RNA of the virus. There is a specific portion, a fragment of this RNA that is specific to the coronavirus that we're dealing with, the SARS-CoV-2, that this test look for. They do not look for the surface protein. They do not look for any other thing else. And once you get your nasopharyngeal swab, the hope is we'll pick up a fragment of this RNA and we'll be able to test to see if it exists. If it's positive, it tells us that you are infected now. If you have antibodies against it, it means most likely you've been infected in the past. But remember, there are other strains of coronavirus that could cross-react and give you a false positive in this instance. There are antigen tests that look for this surface spike protein from your nasopharyngeal swab. Again, if those come back positive, it shows you are infected now. Looking at a rapid antigen test, they are very, very good. If they come back positive, most likely you have it, almost 100% sure. But if they come back negative, in about 50% of situations, it will be a false negative. You may still have it. So that's why the preference is the rapid molecular test, which has a very good sensitivity and specificity. If you don't have it, if it's negative, you most likely don't have it. If it's positive, you most likely have it. And that's why we use molecular tests. This is the reason why it's only the molecular tests that are acceptable if a patient is being transferred from an outside facility. You don't want to bring a patient into the ICU, even though their antigen test says they are negative, but they actually have it. It's really, really poor sensitivity. This is a very busy slide, and I apologize for that. It just shows the various type of tests, and what you really need to focus on with this test are just these numbers here. This was the first test that we started using at JPS, the ID Now. You can see the sensitivity is poor, about 74%, basically saying you can miss 25% of patients. 25% of patients will be stated to be negative that actually have the virus. The only thing is they are very good at telling us if the patient have the virus. But if they come back as negative, the patient could still have it. About 1 out of every 4 patients could have it. And that's why we went to this Heath test that we're currently using. You can see if it says you are negative, you are 99 to 100% sure that you're actually negative. And if it says you are positive, you're actually most likely positive. You can compare the numbers to the antigen test as I showed you earlier. Sometimes it's like flipping a coin. If it says you don't have it, there is 50% chance that you do in fact have the virus. So that's why we don't use it. There's a concept of COVID recovered. There are patients that have been in the hospital for a while that we will label, oh, this patient is COVID recovered. But we'll get a swab from them and it will still come back positive. So what is going on in those instances? The issue is, remember I mentioned earlier that the test that we use to diagnose, the molecular test that look for the RNA, only looks for a fragment of the RNA, not the whole virus itself. So after a while, after someone has had coronavirus and they have been in the hospital for a while, and you still have a nasopharyngeal swab, the possibility exists that you can find some piece of RNA from a degenerating virus that is no longer capable of infection. It's just breaking down. So the test may come back positive, but the patient no longer has the virus. And the way to know is if you culture, there are studies that have looked at culturing those nasopharyngeal swab for a virus that is live. And you can see right here, these black squares are positive culture and these orange circles are negative culture. So if a patient has been having symptoms of coronavirus, after 20 days, really, you cannot isolate a live virus from them. Anything you isolate, even if your tests come back positive after that, is most likely a fragment of the RNA from a degenerating virus that is being picked up, not necessarily that you have a live virus. So that's why usually after 3 weeks, even if a test comes back positive, the patient most certainly does not have a live virus in them and can no longer transmit or infect another person. This again is another way of looking at it. Days after the onset of symptoms, in this study, by day 8, they were unable to culture a virus from all the tests that came back as positive. So most of these other cases are actually just fragments of RNA that have been isolated. As you can see, live virus could not be cultured from all of those samples. This is one of the important slides, looking at the clinical course of COVID-19. As we all know, once somebody is exposed, there is an incubation period, usually on the average of about 5 days. Then they become symptomatic. The viral load or the level of viruses really grows during this period. Then after a while, after about 4 days of symptoms, it starts declining. Then you start having some of the inflammatory situation and then respiratory difficulty and organ failure. But the thing to remember about this is most people only present usually in this zone here. They don't present during the zone of the viremia because all they're having is a little bit of fever, some cough, some headache, some malaise. They will not present to the hospital until they start having a lot of shortness of breath and they cannot do stuff. And on the average, that's usually on day 9, day 10 of illness. And that is important. As you can see, the viral level has really declined by that period. So if you are given any medicine to kill the viruses, once a patient becomes symptomatic, it's not likely to be effective. But we'll talk more about that in subsequent slides. I did put this here for a reason. I alluded to it earlier. This is the coronavirus, and this is the spike protein. This is the receptor it binds on. The key thing to remember about this receptor is, in addition to being a receptor, it's also an enzyme. It works on the angiotensin molecules or the angiotensin pathway. These molecules can be regarded as bad angiotensin, good angiotensin. This enzyme converts bad angiotensin into good angiotensin. But once the virus uses this receptor and it's destroyed, you only have accumulation of bad angiotensin, which contributes to lung injury, heart damage, blood vessel damage, and blood vessel destruction. So this is essentially the same thing as I was alluding to. And this is a summary of what I just said. The virus really gets into the respiratory mucosal cells and destroys the type 1 pneumocyte, type 2 pneumocyte, inflammation ensues, and you start having pulmonary edema in the lung, you start having breakdown of blood vessels in the lungs also. Here is a major difference between other viruses that we know and coronavirus. It not only damaged the respiratory cells, it also really damaged the tiny blood vessels in the lungs. It destroys and breaks them open. So there is a vascular component to COVID-19, and it's foundational in understanding what goes on with COVID-19. This is a long slide of a 79-year-old gentleman that was admitted to the ICU with COVID-19. You can see on day 5, they have ground glass opacities here. By day 21, it's already fibrosis. And here is why. During the earlier part of it, they just have a lot of inflammatory cells in the alveoli. The alveoli is destroyed, broken open. Some of the blood vessels are ruptured. But by day 21, towards the end of second and third week, you start seeing a lot of scar tissue replacing in the lung, a lot of scar tissue around blood vessel, which is typically not usual for what we see in most type of pneumonia. So giving rise to a situation where the ARDS, which is the lung injury disease that is developed with COVID-19, the thinking now is there are 2 types. There is the L type and there is the H type. The L type is usually early. It is when a patient comes to the hospital and you get a CT scan, you just see minor injury. It's just ground glass opacity there. This lung is very, very compliant. Most of our respiratory therapists will understand that. Very compliant. The patient can breathe. They may be saturating at 80%, and yet they will tell you, oh, yeah, I'm fine. Unlike in the later stages, it becomes something like this. There's a lot of atelectasis. There's a lot of consolidation. And the compliance is very, very poor, as we all know in the ICU. So subsequently, I will be referring to the L type and the H type. The L type is early. The H type is late. These have good compliance, which means the lung can expand easily, and these have very, very poor compliance. This is a very interesting CT scan that really drives home all the point I've been trying to make about understanding what goes on with COVID-19. This is a lung CT scan of an 86-year-old nursing home patient that was found unresponsive on the floor in a room at the nursing home. Was brought to the ICU. This was in the UK and was found to have COVID-19. They did a CT scan. Additionally, they did a dual energy CT scan that monitors blood flow in the lung. What they found out is in this area of ground glass opacity that I showed you earlier, you can see the blood vessels in the lung are actually bigger than they should be. All these bright orange areas here, there is good blood flow. But in this dark red area, no blood flow. So the problem with this ground glass opacity, when you see them on X-ray, is not just inflammation. There is also damage to the blood vessels. So even though air can actually technically get into this area, but blood is not perfusing this area of the lung. If blood is not perfusing, it doesn't matter if the oxygen you're given is 100%. There is nothing to carry it. So that is one of the fundamental problems with COVID-19. In addition to being a lung parenchymal disease, it's also a blood vessel disease. So there is no amount of ventilator strategy or ventilator management you can do in this instance that will increase oxygen. If blood is not flowing there, give it 100% oxygen, it doesn't matter. Your patient will still be short of breath and be in trouble. So this is another slide that shows that in the small blood vessels of the lung, you can have blood clots when you're having COVID-19. In addition to damaging the blood vessel, you also have blood clots within the small blood vessel, which is why, again, in those areas of ground glass opacities, there's reduction in blood flow to those portions of the lungs. Once there is blood vessel damage, the blood vessel will always try to repair itself. By trying to repair itself, it forms new blood vessels. These young blood vessels are very fragile and they can rupture and bleed easily, which is why sometimes in the ICU, Despite saying the patient has a high propensity of clotting off, they also have a high risk of bleeding from this new young blood vessel that can easily rupture, especially if you are giving them anticoagulation. Yes, in this slide, I showed you that there is blood clot formation, which will give anticoagulation for. But at the same time, you have new blood vessel that is growing that can rupture easily. And when you compare the lung of a patient with COVID-19 to that of a patient with influenza, they are creating about 3 to 4 times more young blood vessels that are fragile and can easily break up. That's one more reason why COVID-19 is not the same as influenza. This is a summary of what I've been saying earlier on. So both L and H types of COVID-19 associated ARDS, they are extreme. Early, people present as L type usually, and late, L types become H type. Most people with L type, though, they will come to the hospital, as we see in the care pathway at JPS. They get admitted to the PCU, they are L types, they do well, they recover and go home. If a patient is L type, just leave them alone. Doing too much really could be risky. If for an unfortunate reason they progress to the H type, then you can manage them via the usual ARDS. Now, the question always arises, when should we intubate a patient? And this is an intense area of controversy. For people that work on the floor, when should we consult the ICU for transfer of a patient to the intensive care unit? I'm going to start with this slide to just make a point. If a patient is on a non-invasive support, high-flow nasal cannula, if you intubate them at about 6 hours, if you use that as a benchmark to say, okay, what's the mortality for somebody that requires non-invasive support at 6 hours compared to at 72 hours? If you delay intubation, the mortality rises. This slide would tend to suggest that you probably are better off intubating somebody on high-flow nasal cannula early and not wait until late. But there is more to it. Remember this slide. For those that are intubated in our ICU, the mortality is 53%. Those that are not intubated, the mortality is 14.5%. To get from being non-intubated to intubated, mortality jumps to 40%. Now, most people that progress from being non-intubated to being intubated do so primarily because of worsening of their underlying disease condition. They just get worse. But we gotta be careful on how we select patients for intubation, because inadvertently we may cause a little bit more problem. Now, I have this slide as a preamble to the next slide that I'm going to show. Patients that are breathing spontaneously, you and I, our pleural pressure is between -2 to -8. And the transpulmonary pressure acting on this lung right here is 0 minus -8, which is +8. I'm going to jump to this because this is where I want to make my point. For somebody that is on mask ventilation, for example, IPAP or CPAP of 10, and you're forcing air into their lungs, and they are also struggling to breathe, they are taking large tidal volume, they generate a lot of negative pressure inside their lung. So the total pressure acting on this alveoli here, or on this lung here, is actually quite high. Some of these patients generate up to -40, some generate up to -30. So you can see how the pressure can quickly pile up. So in a patient that is breathing via a mask, and they are generating a lot of pressure, they can self-injure their lungs. So this is patient-directed self-injury of their lung that you really have to be careful about in a patient that is receiving non-invasive ventilation. Some people believe that the reason to intubate a patient that is on a masked ventilation is to actually prevent that patient's self-injury. You don't want them to injure their lung by generating a lot of negative intrathoracic pressure. But at the same time, there are arguments that this is not the case and you should not intubate all of those patients. So how do you make the decision? Which is the best evidence way to make the decision? If a patient is on a mask ventilation, and this is a very good study, and their tidal volume is greater than 9 cc per kg, they are less likely to survive. And those patients should be intubated. But if their tidal volume is less than 9 cc per kg on a masked ventilation, the argument is leave them alone. Their survival is good. A similar study here, they use a cutoff of 9.5 cc per kg. So if I'm seeing a patient on P4, for example, on mask ventilation, and I look at their tidal volume, they're not drawing in a lot of tidal volume. If it's less than 9 cc per kg ideal body weight, I will leave them alone. If it's more than that, I think that's an indication to move the patient down to the ICU. What if they are on high flow nasal cannula? How do you predict that this patient is going to require mechanical ventilation? We do not have a COVID-specific data, but we can extrapolate data from patients that have pneumonia. There is this ROX index of patients that are on high flow nasal cannula. So I'm seeing a patient on P4 in the emergency room, they are on high flow nasal cannula. If I calculate their ROX index at 2 hours and it's greater than 4.88, they are very likely to do well if I leave them on high flow nasal cannula compared to if I intubate them. The same thing at 6 hours, the same thing at 12 hours. So the objective way for high flow nasal cannula is to calculate their ROX index. What is ROX index? This is ROX index. It's on MD Calc and you can find it. Play around with it. Like if I enter, my patient saturation is 90% and their FiO2 is 90 and they're breathing at 22. Their ROX index is 4.5. This paper will argue that you should just watch them closely. You don't need to intubate them. It combines three things: respiratory rate, O2 saturation, and FiO2. And on the basis of that, you can calculate it. It's a very good predictor, as you can see here. It can correctly identify up to 80% of patients on high flow nasal cannula that will do well versus those that will not do well. So it's a really, really very useful tool. So mechanical ventilation management, we all know about the 6 cc per kg for patients that are admitted to the ICU. You keep the tidal volume low on those patients. There is no advantage to doing the traditional high tidal volume of about 12 cc per kg. You can get the same minute ventilation in both groups just by increasing your rate rather than use high tidal volume. PaO2 FiO2 ratio is better in people receiving very high tidal volumes compared to people receiving lower tidal volume, telling us that in this group of patients, in ARDS patient, oxygenation is not the issue. It's ventilator mechanics that matters more than oxygenation. So even though these patients are getting very high tidal volumes, they have better oxygenation, by the time it was all said and done, they died more. Low tidal volume died less. They didn't have good oxygenation relative to this group, but they survived more. So respiratory mechanics instead of FiO2. Again, if you break it down and you look at other parameters in ARDS, and you want to figure out, should I adjust my PEEP or should I do my driving pressure? Which one will make my patient do better as far as mechanical ventilator support is concerned? This is your driving pressure. Your driving pressure is plateau pressure minus PEEP. My respiratory therapist and other people that work in the ICU will know about this. In this group of patients, as the driving pressure is increasing, and if you keep your PEEP constant, you can see your mortality is increasing also. Now, if you say, I'm going to keep my driving pressure constant and I will increase my PEEP to increase my oxygenation, it doesn't matter. Your mortality remains the same. What if you do the reverse? Let me make sure my driving pressure is dropping, but I'm increasing my PEEP. Your mortality drops. So clearly, in addition to maintaining a lower plateau pressure, if you want to drill down to it, the two most important things we can do for a patient with ARDS on mechanical ventilation is keep an eye on the driving pressure and keep an eye on the plateau pressure and use low tidal volume. That is what we have the best evidence for. This again is just a reiteration of that once your driving pressure goes above 15, your mortality really, really rises so fast. And that is not oxygenation. That's the issue in the ARDS. Any patient that has ARDS that will die will die. Ventilator cannot fix that. Ventilator is not a treatment. What enhances survival in ARDS is not causing further damage with ventilator. This is a study of ICU in 50 countries. The best predictor of death, again, remains the driving pressure. The higher your driving pressure, the higher the mortality. What about bi-level? Some of us like bi-level, APRV, TCAV. I think they are all semantics. It's all the same. The key thing to remember about this is I wrote this here in small font primarily because there is no data. You will struggle to find any data in ARDS, especially in COVID ARDS. Nobody recommends it. And it's for the simple reason that with bi-level and APRV, your P high is your plateau pressure, your P high is your driving pressure. And usually it's always above 15, especially in this patient. So the potential exists that you're actually causing more harm, regardless of whether or not your oxygenation improved. Oxygen is not the issue in ARDS. Oxygenation is not the issue. What is the issue is respiratory mechanics. Keep your tidal volume low. Keep your plateau pressure as low as possible. And most importantly, keep an eye on the driving pressure. There were 29 patients in our ICU that got some form of APRV, TCAV, or bi-level, and of those, 14 died. Again, that's a small sample size and does not tell us anything much. This is from Mass General. I was interested when I saw that they had the lowest mortality reported in Boston. I went to their website to see what they are doing well. They were very, very clear about it. No APRV. It is not suited for APRV. It does not improve mortality and potentially can cause harm. How about proning? We all know proning works. This was the original study that showed proning at 90 days. The people that were prone had a higher survival compared to people that were not prone. So that is really why we're prone. Again, proning helps improve respiratory mechanics. Clearly, you can see here the mortality in percentage, 16% in the prone group, 32% in the supine group. That's why we try to prone. Even in patients that are obese, it's been shown to help. What about in patients that are not intubated? This was a study in the Blue Journal. Before proning, this is the oxygen saturation of this group of patients. After proning, you can see the oxygen saturation jumps up. But more importantly, I've always said it's not about oxygenation, it's mechanics. 1 hour after proning, their respiratory rate dropped, which means they are doing a whole lot better and their pulmonary dynamics is definitely much better. That's why we encourage self-proning in patients that are not intubated because it works too and it helps them. To paralyze or not, there are two big conflicting studies, and this is an area of uncertainty. The European study was published in 2010. The American study was published in 2019, 9 years between the two. The European study right here was well done. It showed that people that got paralytics, NIMBEX, at 28 days had mortality of 23% versus 33% in people that got placebo, which was significant. And this would tend to suggest that paralytics help in patients with ARDS. And they did not show any increased risk of weakness as one would expect it. But the American study by the NIH says, wait a minute, let's look at this a little bit closer. In here, hospital death at 90 days, there was no difference. 42% mortality, 42% mortality in both the intervention and the control group. So this is uncertain. If you compare the two studies, they both have their weaknesses and strengths. The ROSE trial is the NIH study in the United States, and the accuracies data is a European study right here. The accuracies has a smaller sample size compared to the ROSE trial that enrolled about 1,000 people. The accuracies was blinded. This was not blinded. So again, they have their strengths and weaknesses. So it's an area of uncertainty, especially in COVID-19 patients. We use a lot of paralytics, but paralytics in and of by themselves do not improve outcome. They should be targeted at improving pulmonary dynamics and respiratory mechanics. That is the only thing. Not targeted at oxygenation, but just respiratory dynamics. In summary, in regards to paralytics, please analgesia first, then sedate. Once the dose of these two are at maximum, only then should we paralyze patients. The other key thing to remember is you do not win analgesia and sedation until paralytics is completely off. And we have to evaluate our patient every day to determine if we can get them off of paralytics as soon as possible. This probably is the most important thing to know about paralytics. It's an area of uncertainty. We have to use it in a goal-directed fashion to really improve respiratory mechanics and patient-ventilator interaction. Again, this is summary. Patients with COVID-19, they come in profound hypoxemia. And earlier on, most patients have good compliance. What you don't want to do by intubating patient early is to convert the L-type ARDS to the H-type ARDS and increase mortality by up to 40%. You really want to identify as much as we can patients that will benefit from that escalation in terms of protecting their lungs and giving them the best chance at recovery. So avoiding delayed intubation is the key rather than early intubation. I know that sounds like splitting hairs, but that's exactly what has to be done. And we have tools that can help us with patients on CPAP and tools that can help us with patients on high flow oxygen. What about fluid? Should we be conservative with fluid therapy or should we be aggressive and diurese our patient? This is fluid management in ARDS, is the best data we have out there. And as you can see right here, people that got conservative strategy, that means you give little fluid to and you diurese, they came off of the ventilator much sooner than people that were getting a lot of fluid and less diuretics. Even though the mortality is not statistically significant, but there was a clear trend towards lower mortality in the conservative group. But that is not the end of the story. This is the chart of the group. In people that were in the conservative group, they got a lot of Lasix compared to people that are in the liberal arm. People that were conservative also, they got less fluid compared to the people in the liberal. And as expected, they put out more fluid because they were getting Lasix and compared to the liberal arm. And the I's and O's at the end of the day, they were more negative on most days in the ICU compared to the liberal arm that were getting a lot of fluid. So again, we all know that we say in sepsis, we should give a lot of fluid, we should resuscitate people, and sometimes this patient needs to be resuscitated. This is an editorial accompanying that study. The most important thing about fluid therapy is to know which phase we are. Sometimes patients are dry, they're intravascularly depleted, they need to get fluid and vasopressor support, and sometimes we need to diurese them. How did this study I refer to figure it out? They looked at a way of knowing what the intravascular volume is. And if their CVP or wedge pressure is elevated generally, they note that. But they have a major stop. If a patient has a mean arterial pressure less than 60 or they are on any vasopressor except for dopamine, they only give vasopressors and fluid boluses. They do not diurese. So there's a hard stop here. Now, if their MAP is above 60 and they are not on vasopressors, in the conservative arm or the liberal arm, they also now go to, do they have an effective circulation? What's their cardiac output? Are they cold? Are they mortal? Do they have capillary refill or not? If they have low cardiac output, it means they have heart failure. So they use dobutamine with furosemide. If they do not have heart failure, they only use Lasix. And if their urine output is high and they have heart failure, they use dobutamine and Lasix. And if their cardiac output is good, they just use Lasix alone. So that's the general concept. So there's really no need or no use to give a patient that's hypotensive on vasopressor diuretics. What are the other areas that it can affect? This we have all figured out that it's a multi-systemic disease. It can affect a whole lot of organs. But if we look at the kidneys especially, it tends to suffer from COVID-19. Direct effect of the virus can damage the kidney. In addition to damaging the lung, the virus can directly infect the kidney and damage the kidney. A lot of the other septic shock and other issues going on, fever, and the immune response can also damage the kidneys. This slide here is very busy, but I just want to draw your attention to a lot of studies that have looked at. In this study, for example, 100% of patients they looked at were admitted to the ICU, and about 31%, 1 in 3, required renal replacement therapy. So the key thing that they recommend is you really have to individualize fluid and hemodynamic management. And you have to do a dynamic assessment of the cardiovascular status before you start deciding whether or not you're going to diurese or use vasopressors in this patient. What about the heart? The mortality becomes really high if you have any elevation of troponin, especially if you have an underlying coronary artery disease. The same thing here. Patient that will die, the troponin keeps rising. Patient that will survive, the troponin drops. And the same thing with BNP. It rises in folks that die and it decreases in folks that will survive. What about cardiac arrest in the ICU amongst COVID-19 patients? The key thing to remember is most patients with COVID-19, their initial rhythm is asystole. Overwhelming majority of this patient, 122 out of about 134 patients presented with asystole that had cardiac arrest. How many of them had ROSC? Only about 9%, but how many survived the hospital stay? Only 1. So if a patient has COVID and they go into cardiac arrest, they are most likely going to present with asystole and their survival is poor. This should aid in conversation with family in regards to goals of care and likelihood of survival. Do patients with COVID-19 actually have a storm? Accumulating evidence suggests they do not. So this is the IL-6 level in patients that had COVID-19. You can see the levels here, 7, 45, 21. This is patients that normally just have ARDS. You can see the IL-6 level is much more higher. Even in severe disease, they have a higher IL-6 level than somebody with severe COVID. No wonder tocilizumab did not work and we have to stop. You can see again, this is looking at interleukin-6. Clearly, even some sepsis patients have more IL-6 than COVID patients. These are other inflammatory markers that show the same thing basically. So it appears there is no cytokine storm in COVID. And I think we were right in stopping tocilizumab early. It was just causing a higher rate of hospital-acquired infection and candidal infection. The Solidarity trial from WHO looked at remdesivir in terms of remdesivir versus placebo. Does it work? It does not. It's no better than placebo in all comers in the WHO study. So essentially, it was a negative study. And this is why WHO does not recommend remdesivir for use in therapy of COVID-19. But that is not the whole story. This is the US study that looked at remdesivir. You can see if you break it down to subgroups, in patients that are receiving oxygen, in patients not receiving oxygen, and in patients receiving high flow or non-invasive mechanical ventilation, and in patients receiving mechanical ventilation. Here is what it shows. If you come in requiring mechanical ventilation, remdesivir is most likely not helpful. It's probably too late. If you are not requiring oxygen, it's not helpful. It's probably too late. But if you are requiring oxygen, just nasal cannula oxygen is probably a little bit helpful. If you are requiring CPAP, BiPAP, or high flow nasal cannula, it's really not helpful in terms of overall recovery or in terms of overall outcomes. So again, if you now look further at the subset of the patient, I just want to draw your attention to this. In people that present with symptoms duration of less than 10 days, they really benefited from remdesivir. You can see remdesivir is better. But after 10 days, it is not helpful, which will really remind us of this. People that present here where the virus is still going rampage before the immune system starts killing the virus, they will benefit from remdesivir. But if they present at this stage, they are not likely to benefit from remdesivir, and it's probably too late. Again, the same thing here that I just said. They benefit in terms of quick recovery, less hospitalization. This is the same thing I just said, comparing all the studies that have looked at remdesivir, Solidarity, the ACT study, and also the study from China. Again, low flow oxygen, presenting early, remdesivir is better. What about plasma? Generally, people that got plasma, look at the percent of death, 11% versus 11.4%, no benefit. This study shows that getting convalescent plasma from people that recovered from COVID, like we were doing aggressively earlier, is not really impacting. And you can see this is a trend. People that got plasma, 7 days after getting the plasma, more of the people that did not get plasma are already being discharged with full recovery. And you can see it persists. More people get discharged that did not get plasma than people that got the plasma. And the number of deaths is about the same in all of them after 30 days of getting plasma. So this strongly argues that plasma is likely not helpful. Again, this is the Kaplan-Meier curve. It's not helpful. It's the same thing. The probability of discharge at 30 days is the same thing, whether or not you get plasma. But beyond that, this is really a very good study from India that shows people that got convalescent plasma plus best standard of care versus people that just got standard of care. Giving convalescent plasma does not affect their level of inflammatory markers. Ferritin is the same. C-reactive protein, the same. LDH, the same. D-dimer levels, the same. So it does not impact the outcome in the disease. What about the antibodies that you are able to measure in the patient? The whole rationale for giving convalescent plasma is so that the antibody in the convalescent plasma can help kill the virus. So if you give convalescent plasma and you start checking the antibody level in the patient on the day you gave it, 3 days after you gave it, and 7 days after you gave it, actually, it appears that if you do not get convalescent plasma, you make more antibodies of your own. And it's appearing as though convalescent plasma may actually reduce your ability to form your own antibody. That is what this study will suggest, which is quite interesting. So it appears the jury on that finally is 17% of people that got convalescent plasma that you were able to actually dictate neutralizing antibodies in their blood died versus 18% that did not get it. Really no difference. So these are two very good studies, in my opinion, that shows convalescent plasma does not work. What about steroid? Steroid does work in almost every group of patients. All people that come, if you take all comers, it reduces mortality. At 28 days, the mortality is lower compared to usual care. People that get mechanical ventilation, it seems that the mortality is way higher if you do not get steroid compared to if you get steroid. This here also shows that if you're on oxygen only, your mortality is lower at 28 days if you get steroid versus the usual care. What about a family member at home that got COVID, but they are doing well, they are not on oxygen? If you give them steroid, they are more likely to die than just leaving them alone. So if somebody is fine at home, they are not sick, they are not requiring oxygen, just leave them alone. Steroid is not beneficial in that group of patients. And this is the same thing that's been said there. This is the overall study. Clearly, 22.9% versus 25.7% mortality. Vaccines, there are a lot of different vaccines that are out there. You can see those that are protein-based, those that are vectored, and I'm going to explain briefly what each and every one of these means, and nucleic acid-based inactivated virus. There's a lot of vaccine in development for COVID-19. Again, as a refresher, this is the spike protein here on the surface of the virus. There are other proteins that can be targeted, but this is the one that really helps. Antibody against the spike protein is really what helps in killing the virus. As a reminder also, this is an RNA virus. It's right here in the center. mRNA vaccine really has been going on for a while, and people have really been trying to create mRNA vaccine. But of course, coronavirus really accelerated the process. Normal vaccine development will probably take about 15 years, or about 5 years until FDA approval, about 15 years or longer until it becomes widely available. But in this instance, because of the mRNA technology, everything has been shortened to between 10 months and 1.5 years. This is what gives a lot of people concern. But the technology is quite robust. Once you understand it, you will see why this is actually a good thing and not a bad thing. This is the basic design of the mRNA vaccine, and I'm going to go into specifics real quickly. They created in the lab a fake virus with its own envelope around it, and they put in some mRNA, not the whole mRNA of the virus, just the portion of the mRNA that is responsible for synthesizing the spike protein. So you are not getting the whole viral mRNA, just a fragment of it. Then it's injected into the blood. The problem is it's highly unstable. People sometimes worry that, oh, it's going to stay in my body or it's going to get into the nucleus and cause problem in my cell down the road. No, the problem with it is actually the opposite. It is highly unstable and it doesn't stay long in the body. If you are lucky or you get adequate enough doses, it gets taken up by the cell. This is the fragment of the mRNA. It is now read and the protein is synthesized from the mRNA. So once you synthesize it, again, it is really capped. This prevents it from going into the nucleus. It doesn't get into the nucleus. Once the immune cell picks up that mRNA in that lipid bilayer, it goes to the local lymph node and they start producing the spike protein only, not the complete virus, just the spike protein. And they use that to train the immune cells. So you have cytotoxic T cell that will develop that will be able to recognize the spike protein of the virus on subsequent exposure. And you also have the B cells producing antibodies that can kill the virus once exposed again. So there are three types of vaccine now, as you all know. There is the Pfizer vaccine, there's the Moderna, and there's the Astrazeneca, which is the UK vaccine. All of them are mRNA technology. And of course, everybody have heard all of these numbers. They are very efficient. These are mRNA that has been built inside a lipid bilayer, the lipid bubble that takes it into the cell. The AstraZeneca vaccine, they use a virus that they have hollowed out, an adenovirus that doesn't cause human infection. They hollow it out, remove its own genetic material, and put in this mRNA inside of the virus, and they use it to infect the body. That is not really showing a whole lot of good results. They still need to get more data until anybody will be able to recommend this vaccine. But the Pfizer and the Moderna vaccine, I think, are very good and they are ready for prime time. Compared to the flu vaccine that is only 44% effective, the AstraZeneca is 70%. The chickenpox vaccine, for example, is 92% effective. The Moderna and Pfizer are 95% effective. Now, it's no walk in the park. There are associated side effects in terms of having fever, fatigue, myalgia, local symptoms, erythema and redness, and swelling and pain. You will actually have more symptoms when you get the booster dose of the vaccine. This orange bar represents the proportion of people with severe symptoms. Majority of people will only have mild reaction to the vaccine. But for some people, you will know you got a vaccine, which in itself is a good thing. You have to weigh the risk against getting the whole viral mRNA by way of infection and knowing the risk of not knowing how your immune system is going to handle it. Overall, I think this is a safe bet. This is the antibody production, looking at the Moderna vaccine compared to people that actually recovered from the infection. On day one, after people got the infection, they only have small amount of detectable, insignificant antibody. But by day 15, look at the titer, 163,000 compared to 142 average in people that have recovered. And by day 57, after you got the second dose, you're at 1 million, 1.1 million compared to 142,000 titer in the convalescent serum. Even if you use the dummy virus, your antibody destroys it that you get from the Moderna vaccine. This is just really repeating the same thing. It really generates, and it is an effective vaccine. That's what the data is showing. And you're comparing to the convalescent serum. In most instances, it's actually better than having the infection itself. Again, these are various immune cell response. This is the Pfizer vaccine. The same thing, right? You will know that you took something. There's a lot of local side effect, mainly pain at the injection site that you will feel, and also some swelling and redness and a little bit of fever. Here also, especially in the elderly, you can see they had a whole lot more fever and fatigue, especially after the second dose of the Pfizer vaccine. After the second dose of the Pfizer vaccine, even young folks will also feel some side effect. Again, it is highly immunogenic. You have very good response. This is human convalescent serum. You can see in most instances at various doses, the vaccine actually beats having the virus. The decision point now is, what are you going to do? The vaccine only gives you a small portion of the mRNA to allow your body to synthesize only the spike protein, and you'll be protected from the virus. Weighing that against the risk of exposure to the virus and getting the whole mRNA and having an inferior protection against the virus. So overall, in my opinion, based on my understanding of the data, I think one is better off getting the vaccine, and I intend to get the vaccine.
Once the patients reach the H level of the disease and that portion of the lung has no perfusion and they live, what is the long-term outcome of those people? Do they have chronic disease? Do they have reduced lung function? And is there anything that we can do early to reduce the chance of them moving into that, or is it just part of their immunologic function?
Excellent question. There is a pattern emerging now, even in inpatient. In people that have progressed to the H variant, ARDS, related to COVID-19, they really heal by fibrosis. Interestingly, I've been rounding on a pulmonary inpatient consult in the last several days, and I'm seeing people that have recovered from COVID coming back to the hospital with interstitial lung disease that is now going into some sort of acute exacerbation with worsening chest x-ray. Just like somebody that has ILD that now gets admitted to the hospital with acute exacerbation of the ILD. So I think you're onto something there with your question. The reason is, I think this really is a function of the immune system. And there's still a few things that we still do not understand on the back end of this disease that we're now beginning to see and accumulate a lot of data. So I think you're right that in addition to this fibrotic lung disease, which is immune dependent, there is still consequences down the road. We are now beginning to see them coming back in with exacerbation of that ILD itself. I think more will follow on post-COVID lung disease. I definitely agree. That is a thing.
Just to add to that, there seems to be, at least in my mind, a bimodal distribution of survival. That if you get intubated early on, you tend to do much better and tend to get off the vent much faster. But the folks that languish on Airvo for a couple of weeks, to Dr. Badamosi's point, sort of a continued flow of inflammation, those folks do significantly worse. So I think there's going to be something to, when you look at that first group, how quickly they respond. In a sense, are they getting their immune system in check and they don't progress to a late stage fibrotic disease? I think there's going to be a signal there. And how do we predict, or how can we actually move people to being that quicker sick and then done, as opposed to the lingerers?
Yeah, and I think probably that may be one of the signals we're seeing in regards to the steroid, in terms of really applying the brakes on the immune system, in terms of slowing things down and really tampering down the inflammation. This is the biggest thing that struck me as I begin to look at a lot of this data in preparation for this talk is how much of COVID is a vascular disease than actually a pulmonary parenchymal disease. So that there's a lot of vascular injury that perpetuates pulmonary ischemia, pulmonary infarction, further injury, and fibrosis. So I think that is the key. And to the specific point you raised again, finding out about the ROX index and the stratification of mask ventilation by the approximate tidal volume, I think that has to be really our decision point in regards to, should we intubate this patient or should we leave this patient alone? Because it gives us about, in 80% of situations, we will be right, rather than just going by clinical gestalt. I think those objective data will help us eliminate our clinical feeling or biases against the time of when we need to intubate a patient.
One more quick question on that note, Dr. Badamosi, because I totally agree with you that this is an alveolar capillary membrane problem, much more than a parenchymal problem. And we found that out relatively early, knowing that we have seen quite a few patients with relatively minor disease, then subsequently developing significant thrombotic events later on. Should all of these patients receive some type of prolonged anticoagulation during the recovery phase and beyond to prevent some of the sequelae of the thrombotic side of this viral illness?
Absolutely. Every single guideline recommendation and data I saw will agree with that point. For at least 30 days afterwards, they should be anticoagulated, especially if they're admitted to the hospital. I think it's a great practice because we've seen a lot of people come back a few weeks after recovering with PEs, myocardial infarction, and other thrombotic complications. Absolutely, I agree with supported by the data.
Dr. Alawi is managing a huge amount of people as an outpatient with supplemental oxygen. They have symptoms, but they're not admitted to the hospital. Should those patients also be anticoagulated?
If they require oxygen, I will err, based on my understanding of the pathophysiology of this disease, I definitely will err on anticoagulation, even if it's with the NOACs, to really kind of like make sure that they're not going to form blood clot. Because what gets people in trouble is actually those blood clots, pulmonary ischemia, and viral damage, and then fibrotic lung disease follows. So if one reduces the likelihood of forming those microthrombi in the lungs, then there is less likelihood, in my mind, of disease progression and complication down the road. There is a study that's actually ongoing looking at this issue specifically in terms of does anticoagulation as a whole benefit, and if you stratify by degree of illness. I think that will be very informative once it is published. Sorry, we ran over a little bit. I hope everyone has a pleasant day.